All right, everyone, we are going to go ahead and begin our presentation today. If we could go to the next slide, please. Welcome, and on behalf of NHF, welcome to the Basics of Hemophilia. My name is Natalia Winberry, Manager of Education at the National Hemophilia Foundation. Our speaker today is Sue Garrity, retired nurse coordinator at the University of Colorado Hemophilia and Thrombosis Center. Next slide, please. I wanted to give you a couple of tips about getting the most from this session. So as I mentioned earlier, and if you're just joining us, this presentation does feature audience interaction through Mentimeter. So when you're prompted, please go to www.menti.com in either another browser or a second device and key in the code at the top of this slide. So you'll see at the top of the slide, it says www.menti.com. Use the code 39086095, and you'll be able to follow our presentation and engage in our audience interaction points. We would also like to remind you to use the chat box to write in questions or comments. The speaker will try to respond to as many as possible during our Q&A portion that'll be at the end of our session. We also want to remind you to please be sure to give additional feedback at the end by filling out the evaluation. And we also wanted to note that the presentation will be recorded and will be available to watch after this session. And again, I'm going to remind everybody, because we are doing this awesome audience interaction piece, please go to www.menti.com, key in that code at the top of the slide, 39086095, and you'll be able to engage with this presentation. Next slide, please. We have the following disclosures for our presenter today, Sue Garrity. And with that, I would love to turn to our wonderful session, The Basics of Hemophilia, and I will turn it now over to our speaker, Sue.
Thanks, Natalia, and thanks to all of you who are joining here. It's afternoon where you are, it's still morning where I am, but want to review the objectives that we're going to go over during this session today. We're going to review hemophilia and understand how it is passed on. We're going to identify the types of bleeding, including signs and symptoms of bleeds. We're going to discuss prevention and management of those bleeding episodes. And finally, we're going to review other aspects of caring for a child or taking care of yourself or another adult with hemophilia. Next slide, please. In order to get a feel for what I should concentrate on during this talk, we're going to have you all go to Mentimeter and type in or select what type of hemophilia affects your family. Hemophilia A, Hemophilia B, or other, and other would include other factor deficiencies, as well as looking at those families who are affected with von Willebrand's disease. Oh, lots of others joining us. We'll just give it a couple more seconds and then we'll go on. Okay, next slide, please. So we're going to start out by talking about hemophilia A. Hemophilia A is also called factor VIII deficiency. It sometimes is referred to as classic hemophilia. It affects about 80% of those patients who have hemophilia. That's why it's not surprising that there were more hemophilia A patients who entered in the last slide. It affects 1 in 5,000 live births, and it is an X-linked inherited disorder. We're going to talk about that here in a little bit. And 70% of patients who are born with hemophilia have a family history. And that means 30% of those who are born with hemophilia have no family history. The hallmark sign and symptom of hemophilia is prolonged bleeding. And about 25% of hemophilia A patients develop an inhibitor or an antibody against infused factor. And this happens to be more common in those of African American and Hispanic descent. Next slide, please. Hemophilia B accounts for about 20% of our hemophilia patients. It also goes by the name of factor IX deficiency or Christmas disease. It's 4 times less common, as I mentioned, but just like hemophilia A, it is an X-linked inherited disorder. But again, only 70% of those patients affected with hemophilia B have a family history. Like hemophilia A, the hallmark sign of hemophilia is prolonged bleeding. But different than hemophilia A, only about 5% of patients with hemophilia B will develop that antibody against factor. But they can also develop an allergic reaction to factor, which is much less common in those patients with hemophilia A. Next slide, please. And of course, there are other factor deficiencies that fall under the big overhead umbrella of hemophilia and bleeding disorders. Factor 1, which is also known as fibrinogen. If you're missing fibrinogen, you have afibrinogenemia. Factor 2 is known as prothrombin. Then factor 5, 7, 10, 11, and 13, we can also be deficient in those. If you're deficient in factor 11, it is sometimes referred to as hemophilia C. And I noticed on the Mentimeter poll, there were a lot of people with other factor deficiencies. So you may be affected by one of these, or you may also have von Willebrand's disease. And with that, I will say, with the exception of the X-linked inherited slides that I'm going to talk about, the remainder of the talk pertains to anyone with these bleeding disorders, as well as von Willebrand's disease. Next slide, please. So we're going to delve into the genetics of hemophilia. And again, as I mentioned, this is going to be for hemophilia A or factor VIII deficiency and hemophilia B factor IX deficiency. Those are both what we call X-linked inherited disorders. The scenario on the left-hand side is depicted where mother is a carrier. Men have one X and one Y, and women have 2 X's. So if you are a carrier of hemophilia, one of your X's will carry the gene that is defective that causes hemophilia. The other X is completely normal. Assuming you marry someone who does not have hemophilia, their X does not carry a hemophilia gene. So when you have children, you have a 50% chance of having an affected child. And that is because mom is going to give one of her 2 X's to the baby. If she gives her normal X, then the baby boy or baby girl will not be affected by hemophilia. If the mom gives her X that carries the hemophilia gene, if she gives it to a little girl, the little girl will be just like mom. She will have one X with the gene and one with the normal gene for factor deficiency, and may or may not exhibit signs of bleeding, whereas a little boy will get the Y from dad and the X from mom, and therefore he will be affected with hemophilia. That little boy grows up, and we see him depicted on the right-hand side of the slide now. He marries someone who is not a carrier of hemophilia, and together they have children. If he will give his X, which carries the hemophilia gene, to his daughters, along with the normal X from mom, therefore all of his daughters are what we call obligate carriers. So some of you who may be listening had a father who had hemophilia, and that automatically makes you a carrier of hemophilia. And then all of father's sons will be normal because his Y does not carry the hemophilia defect. Next slide, please. But remember, I said that 70% of people have a family history. And there are patients who are born with hemophilia who have no family history. And that mutation in the factor gene, whether factor VIII or factor IX, can occur either in the mother as a carrier or in the child, affecting them with hemophilia. So it does occur in about 30%. Now, sometimes families think they don't have a family history, and when we delve into it a little bit in more detail, we do find out that maybe great Uncle Sam was a free bleeder or had some easy bruising or something that may indicate that there possibly was a family history. But like I said, 30% of those patients affected with hemophilia have no family history. Going forward, their family will now have a family history of hemophilia. Next slide, please. And remember I said when we were talking about the transmission of the genes that mom could give her good gene to a daughter, and that daughter would not be affected with hemophilia. If she gives the gene that she has, the X chromosome that has the hemophilia defect on it, then that daughter will be a carrier just like mom. And in a perfect world, our bodies would turn off half of our X's and leave half of them working. And they would do it in a very orderly manner, but that's not what happens in science. So sometimes women who are carriers of hemophilia turn off too many of the normal X's and leave too many of the X's with the hemophilia gene turned on. So they may actually have a factor 8 or factor 9 level less than 40%, giving them a diagnosis of mild hemophilia, or more severe depending on what their level actually is. They should receive care just as their male counterparts. And sometimes even carriers who have a level greater than 40% of factor will still have increased bleeding. So this is I won't say it's a relatively new area, but it's a newly recognized area where we're really trying to hone in on women who have bleeding disorders, and those who are carriers of hemophilia A and B are some of the primary women we're looking at. And so really all carriers should have factor levels checked and should have a thorough evaluation of their bleeding history. Next slide, please. So now we're having another Mentimeter question. So did you have a family history of hemophilia? So if you want to go on and answer this, that would be great. Okay, it looks like the larger majority of people here had no family history of hemophilia, or maybe no family history of the bleeding disorder that they're affected with, but 2 participants did have a family history. Next slide, please. So that's a little unbalanced from our 70-30. So how do we diagnose hemophilia? Well, if we know that there's a family history, prenatal diagnosis can be done. It does carry a risk of miscarriage. And there are 2 ways we do prenatal diagnosis. One is called chorionic villus sampling, where they take a little piece of tissue from the fetus themselves. Or the other way is amniocentesis, which is where we take a sample of the amniotic fluid from the sac around the baby. And we look at the genes in either in the tissue or in the fluid. But what's crucial to doing this prenatal diagnosis is knowing the family mutation. So if you have a family history of hemophilia, in order to do prenatal diagnosis, we do need to know these genes that cause hemophilia are extremely large genes, and it's very difficult. There are a lot of different mutations that can cause bleeding. So we need to kind of be able to hone in on where in that big gene we need to look for to see if the baby's affected. But if we have a family history and you don't know, say, for example, your grandfather or great uncle or someone passed away and you didn't have the DNA to get that mutation, we can still do newborn evaluation. And what we do there is draw some blood from the cord, the umbilical cord, and test it for the specific factor deficiency in the family. Usually that's very effective, but it has to be planned ahead for. So if you haven't worked with the treatment center, or if you didn't have a great experience with your first pregnancy and now you're pregnant again, you want to work closely with the hemophilia center to make sure wherever you're delivering has the capability of getting that cord blood sample and either testing it there at their facility or shipping it off to somewhere else. If there is no If there's no family history, usually the evaluation takes place in the newborn because they had some bleeding, either bleeding from a heel stick, bleeding from circumcision. Although there are children who are born with hemophilia who fly past those two points without any bleeding. But when we're looking at, say your child is now 3 or 4 and they've been covered with bruises their whole life, and your pediatrician is recommending that you be worked up for a bleeding disorder, we start out by doing screening tests, one called a PT-PTT, and then we look for specific factors after that if that test is prolonged. Next slide. So this is just a brief overview of how clotting actually happens. So when we have an injury to a blood vessel wall, we start to leak blood out of that blood vessel. Our body says this isn't normal. It squeezes down and does something we call vasoconstriction to try to plug the hole. When that doesn't work, the body sends platelets, which are circulating in our blood, to actually plug the hole. And then the factors come in and make a safety net over that platelet plug so that healing can take place. Next slide, please. But in hemophilia, you can see depicted in that bottom panel that the platelets make the plug, but then there's either not enough or no clotting factor 8 or 9 to help make that safety net. And that platelet plug falls apart, and then you continue to bleed. What you need to remember is the bleeding is not any longer or not any faster than someone who doesn't have hemophilia, but it's longer because it doesn't stop. Next slide, please. And then we look at how much factor you're missing or how much factor you have. Depends on whether you're a glass half full or a glass half empty person. But when we're looking at factor, those of us who are not affected with a bleeding disorder have between 50 and 150% clotting factor. If you are missing some of that and you have between 5 and 40%, you're said to have mild hemophilia. If you have between 1 and 5% clotting factor circulating, you're said to have moderate. And if you have less than 1% factor, you're considered severe. And this is true pretty much across the board with little changes depending on the type of bleeding disorder you have. But by and large, we do try to classify all bleeding disorders as mild, moderate, and severe, maybe not using those exact terms. So next slide, please. So how can we prevent bleeding? Well, bleeding happens when we have an injury. And for those of us who don't have a bleeding disorder, we probably injure blood vessels many, many times during the day. And our body responds, like I showed you in that panel, vasoconstriction, platelet plug, our factor 8 and factor 9 stop the bleeding. And we never even know these bleeds happen. But if you have hemophilia and that bleeding doesn't stop and you continue to have oozing, then you have bleeding episodes. And we're going to talk about what some of those look like here in a couple of minutes. But how can we prevent them? Well, we can prevent them by using prophylaxis. And prophylaxis is giving factor preventively. We started handing this, we started out treating patients only with severe hemophilia with prophylaxis, and now it's offered to even families with moderate and mild hemophilia. And this is just giving regular factor. And now that we have long-acting factors, it can be once a week, it can be twice a week, it could be every other day, and it could be using a plasma-derived product, which comes from human blood. Our counterparts with von Willebrand's disease that have severe von Willebrand's disease oftentimes are using a plasma-derived product, where most people with hemophilia A and hemophilia B will be using recombinant or a genetically engineered factor. And then today, for those patients with hemophilia A only, there is a new product that's available. It's called a mimetic. Some of you may have heard the term Hemlibra. That's the name of the product. The generic name is emicizumab. Next slide, please. And this particular product, like I said, it works only for those patients with hemophilia A or factor VIII deficiency, but it will, there are products in the pipeline for those of you with factor IX deficiency who may be listening. But what this emicizumab does is it mimics factor VIII and brings factor 10, it bridges 9A to 10 in the clotting cascade. So the nice thing about this product is it is administered subcutaneously or under the skin, just like someone who gets insulin for diabetes. And it can be done once a week, once every 2 weeks, or even once a month. So again, this is something you can have a discussion with your healthcare provider about if this is something you're interested in. Next slide, please. But remember, not everyone has severe or even moderate hemophilia or is a mild patient that requires prophylaxis. So not everyone affected with hemophilia or a bleeding disorder has prophylaxis or is on prophylaxis. So some of you who are listening who may have von Willebrand's disease or another clotting deficiency may not be on prophylaxis either because there isn't a product available for you or you don't bleed frequently enough. So there are a lot of reasons that patients are not on prophylaxis. Sometimes we refer to treating patients when they have a bleed as treating on demand, and that's when a bleeding episode occurs. We encourage all patients who are treating on demand to get treatment within 2 hours of recognizing a bleed is starting, whether you're self-infusing at home or if you have to go into a clinic or an emergency room for that treatment. And then what type of bleeding episode you have is going to determine the length of treatment, how many doses you need, and how long you're going to be on that therapy. And I just want to add a little caveat here. For those patients who are on prophylaxis or using emicizumab as a preventive therapy, you can still have bleeding disorder or bleeding episodes, and those bleeding episodes need to be treated within 2 hours of recognition, just like someone who is treating on demand. Next slide, please. So this has absolutely nothing to do with hemophilia, but just a fun question. So what is your go-to family fun meal? And we have pizza, tacos, spaghetti, breakfast for dinner, or other. And if I was on Mentimeter and I was answering this question, I'd be over there with the pizza people. I could eat pizza for lunch, for breakfast, for dinner. I love pizza. So looks like we have a few taco fans. Oh, tacos tied with pizza. All right, let's go to the next slide. So let's talk about the types of bleeds that you can have when you have hemophilia. We can see bleeding into joints, which are often referred to as hemarthrosis. We can have bleeding into muscles. We can have soft tissue bleeding. And those of you who may be listening that have von Willebrand's disease or another bleeding disorder, often soft tissue bleeding is the hallmark of your bleeding disorder, whereas joint bleeding is typically the hallmark of those patients affected with hemophilia. And then obviously, anytime you have any type of bleeding disorder, you could experience potentially life-threatening bleeds. Next slide, please. So, signs and symptoms of bleeds. You know, it's hard when you're dealing with someone who is not verbal yet. So an infant, a baby, a child who is just learning to talk. So we have to look not only at verbal cues, and we have to look at some subtle cues. So for very young children, if your baby's crying uncontrollably, or in a bad mood, or isn't acting like themselves, it may be a sign or a symptom that they're bleeding somewhere. If they're having difficulty affecting moving an affected area. A hallmark of this is kids who are learning to walk, all of a sudden they revert to crawling. You want to check and make sure there's not something going on in an ankle. For kids who are not verbal, oftentimes we don't see or don't recognize a bleed's happening until we see swelling or the area is warm to the touch. And then skin over the area can become reddened, and or if it's an outward type of bleeding, such as a nosebleed or gum bleeding, bleeding from teeth eruption, you will actually see blood. Next slide, please. So as I mentioned, joint bleeding is kind of the hallmark type of bleeding that patients with hemophilia experience. And there are consequences for having repetitive joint bleeding into the same joint. And this was really what caused us to look at trying to do something prophylactically or prevent bleeding in our patients with hemophilia. When you have repetitive bleeding, it leads to significant degeneration of a joint, or what we call hemophilic arthritis, where the cartilage breaks down and the joint may have limited range of motion. Today, babies born with hemophilia or young children are offered that prophylaxis or prophylactic therapy or preventive therapy in hopes that they don't experience the same type of bleeding that their predecessors did in terms of significant joint hemarthrosis leading to arthritic changes. Next slide, please. I mentioned muscle bleeding. You can see depicted in this picture someone with a thigh bleed or a bleed into their big quadriceps muscle. Bleeding into muscles can cause significant problems because that muscle tissue is encased in something called fascia, and it doesn't stretch. It stretches to a certain point, but then it doesn't stretch anymore. And as a muscle fills with blood, that pressure becomes great, and it can cause actually the muscle tissue to die. So we are very concerned, and sometimes your treatment center may treat a muscle bleed more aggressively than a joint bleed because they're concerned about loss of that muscle tissue. Muscle tissues can occur after vaccinations. They can occur when you have a trauma to the body. They can occur after heavy lifting. Oftentimes you'll hear teens say, oh, I pulled my groin muscle. And really, in someone with a bleeding disorder, that is a muscle bleed. It's not just a muscle pull. Again, another example of this is people say they have a sprained ankle. Well, yes, you stretch the ligaments and muscles around your ankle, but you also have a bleed in that ankle. So treatment for muscle bleeds is extremely important so you don't end up with those complications. Next slide, please. And these are just a couple of pictures of some soft tissue bleeding that occurs. The upper one is a little boy who probably fell on a toy. One of the worst bleeds I ever saw was a kiddo who fell on a golf ball and just landed on it wrong. There are a lot of things we can do to help prevent, especially when your children are learning to walk. Often parents will double diaper their children to give them a little extra padding back on their tush so when they fall, they don't end up with bleeds like this. And then in this lower picture, that's a soft tissue bleed on an arm. But what's of particular note here is if you look at the side of the child's rib cage, you can see these fingerprint bruises. That's very common. And oftentimes we see them in newborns because you know, everybody's excited to have a new baby. Maybe an older sibling is told, hold on to the baby tight, and they hold on to them so tight that they end up with these fingerprint bruises. Sometimes these soft tissue bruises are often mistaken for child abuse, and so parents are sometimes referred to social services, which your treatment center is there for you if something like that should ever happen, to support you and help you through an incident such as that. Next slide, please. And then I mentioned life-threatening bleeds. Anyone with a bleeding disorder can have a potential life-threatening bleed. Obviously, the important life-threatening bleed would be an injury to your head, or that can cause intracranial bleeding or bleeding into your brain. Some of the signs and symptoms of that are nausea, vomiting, headache, drowsiness, and confusion, and eventually loss of consciousness. I think what's key here for those of you listening is to know you're not going to do your child any harm by giving them factor replacement if you suspect a head bleed, but if you take a wait and see attitude for too long, you may do harm to your child. So it's important. It's a fine line, and that's why it's very important to have a good line of communication with your hemophilia treatment center or your healthcare provider. So if you suspect something, you can call and be advised as to whether this is something to watch or this is something to get attention for right away. Bleeding to your neck and throat, that can potentially occlude your airway or make it difficult for you to breathe. Your breathing between your lungs and your nose comes through your throat. So if that gets really swollen, it can shut that down. Abdominal bleeding, bleeding into your gut, either into your upper abdominal tract where you might see blood or coffee grounds looking stuff when you throw up, or blood in your stool. And then that groin bleed that I mentioned before, that's actually a muscle called the iliopsoas muscle. It attaches from your lower back, goes around your hip and into your groin, and you can actually put a lot of your blood volume into that muscle. So if it goes untreated, you can not only have a bad bleeding episode that requires a long period of treatment, but you can also become anemic. You can have trouble breathing because you're not getting enough oxygen from your lungs to your brain. So it's really important to recognize these bleeding episodes. And the hallmark for all of you, whether you're experienced parents listening or your new parents, is pick up the phone and call. It's only a phone call away to get reassured by your healthcare provider or treatment center, but it's just really important to have that two-way conversation. Know who your go-to person is that you're going to call for medical advice at the treatment center. You may have a particular relationship with one nurse or another, or you may be assigned a particular nurse, but know how that's going to work. Do a test run. Say, hey, I just wanted to know how I get hold of you. So I'm just testing it just in case I have a problem. I want to know how I'm going to get hold of you. Next slide, please. And then, of course, there are obvious other bleeding episodes, bleeding from your mouth and your nose. Most of the time for those patients with hemophilia, minor cuts and scrapes are treated just like everybody else with pressure and a Band-Aid. For women, for young ladies who are affected with a bleeding disorder, when they reach menarche or the start of their menstrual bleeding, they can have heavy menstrual bleeding. And again, that you want to have collaboration between a GYN and your hemophilia treatment center to come up with the best treatment plan for heavy menstrual bleeding. And we could do a whole talk on that. But there are other bleeding episodes that you can encounter besides muscle, joint, and soft tissue bleeding. Next slide, please. So let's talk a little bit about how old your affected family member is. Less than 1 year old, 1 to 3, 4 to 10, 11 to 8, or an adult. We'll just take a couple of seconds here. Again, that Menti code is at the top again. I know it disappeared for a while, 3908-6095. Okay, we'll go to our next slide, please. So what happens as your child grows up? Next slide. When your baby is an infant, or typically under the age of 1, the activities that are likely to cause bleeding are circumcision, and as I mentioned before, handling the baby. But this is a time of heightened anxiety for you as parents, and feeling insecure is normal, and you need to be reassured that that's a normal feeling, and that anxiety and insecurity go along not with only having a child with hemophilia, but also with just having a new baby, especially if it's your first baby. So these are normal feelings and things that you should really expect to feel. Next slide, please. As your child begins to explore their environment, they become more mobile, they learn to walk, and this is the time when they experience falls. Again, parents may have been lulled into a sense of security because their baby wasn't moving around that much. They hadn't experienced a bleeding episode yet. And so, they just you need to know this is a heightened anxiety. Next slide, please. School-age children, this is the first time your kid may want to play sports. They are experiencing new environments, going to school, maybe going to a sleepover, camp. And this is when we start to teach children how to infuse themselves or administer their own medications. Next slide. Adolescents, this can be a trying time for all parents, whether they have a child with a bleeding disorder or not. The 3 things that I like to concentrate on with our teens are talking about what you need to do for driving, talking about drinking and drugs and how they can affect your bleeding disorder, and talking about dating. So again, there are new activities. This is when adolescents may hide their bleeding disorder from their friends. And I had already mentioned their heavy menstrual bleeding. And also this is when these guys want to expand their wings and leave the nest. Next slide. Parents don't always want them to leave the nest when they have a bleeding disorder. So briefly, I'm going to quickly cover the last couple of things, some things to consider. Sports, we recommend at treatment centers that your child participate in sports. We do avoid the hard contact sports. Participating sports, whether they're individual sports or team sports, improves self-esteem. It actually decreases muscle and joint bleeding. NHF has a great publication called Playing It Safe. The physical therapist on the teams got together and they developed this brochure, and it's very extensive and really goes over the sports and what the risk factors are that go along with those sports. Next slide, please. Traveling. With COVID, who knows if we're traveling? We weren't traveling, we were traveling, now we're not traveling. But anyway, when we travel again, because we will, you want to plan ahead. You may want to contact the Hemophilia Treatment Center where you're going. Say you're going to Disney World. You want to know where the closest hemophilia center is. Say you're going to Legoland. You want to know where the treatment center is in San Diego. So make sure your child wears a medical alert bracelet. Even if they're resistant to wearing it at home, when you're traveling, it's crucial that they have it on, because you're not going to have your regular healthcare providers right there to answer all your questions. Be sure you don't leave factor in a hot car. It's summer. Hopefully things will start cooling off, but be sure you always throw your factor in a cooler with an ice pack. It doesn't have to be refrigerated, but it does need to be kept cool. When flying, be sure you have a letter from your treatment center that outlines your child's treatment, their bleeding disorder, their treatment plan. Never put factor in checked luggage. Keep it with you, but that means you have to take it through security, so make sure it's in its original box. Next slide, please. And lastly, as I mentioned, comprehensive care, being part of your treatment center or your healthcare provider is crucial. You're the center of that team, and reach out to any members of that team that you need to. You're going to develop a relationship with 1, 2, or many of these people over your child's lifetime. Next slide, please. So if I had to sum up in 2 words, care for a child with hemophilia. One is individual. Just because there's a group of you who had, say, your factor level is less than 1%, that doesn't, just because it's on paper doesn't mean what you're going to experience is going to be the same. So on paper you could look the same, but in real life your experiences can be very different. And this is a partnership. You shouldn't go it alone. Partner with your child, with your spouse, with the community. It does take a village to raise a child with a bleeding disorder. And of course, NHF and HFA and your local chapters are there for you. Next slide. Here are some resources. We can come back to those if we need to. Next slide. So I'm going to skip over this for right now, so we have a couple of minutes for question and answer. So next slide. So with that, I'm going to turn it over for question and answer. If there are any, please type them in to the chat box and they'll get routed by Jay to me. Surely someone has a question. Put the references up again. Can you back those slides up for me, Erica? I think it's 3 back. What do you do if my child? Okay, good question. So what should you do if your child's spending the night with someone? It depends on a couple of things, how old your child is. Obviously, if they're spending the night with grandma or grandpa, they're going to have a better understanding than if they're staying with the neighbor kid down the street. So if your child is on prophylaxis, make sure that they've received their prophylactic dose so that they do have some coverage. And then it's really up to you to decide what you want to share with the family. It is important for the family to that your child is staying with to know that your child does have a bleeding disorder. It's also important to have a conversation with your child that they keep their medical alert bracelet on at all times, and also reassuring the family that, you know, you're around. If they have a question or concern, they should call you. But in essence, treat your child just like any other child that's spending the night. So it really does depend on a lot of circumstances. And I missed that last question. There was another question. What do you recommend to start with treatment? Severe B and is 7 months old. I think for treatment, you need to be talking not to me, you need to be talking to your healthcare provider. When we look at treatment, again, you want to look at what kind of activities you and your family do. Has your child had a bleed? Do you have a family history? That kind of thing. And then it looks like a follow-up is, if a patient's less than a year old, what do you expect with vaccines? Again, I think you're going to defer to your hemophilia treatment center or your healthcare provider and ask them what their policy is. Most hemophilia treatment centers are recommending that the vaccines be given subcutaneously or under the skin. Today, we know that most of them have most children have a good response to the vaccinations when they're given that way. Other treatment centers still may recommend that they're given intramuscularly, but they also may recommend that factors given before or after that time period. And certainly you can always do, whether your child is getting the immunization subcutaneously or intramuscularly, you can also do local measures, applying direct pressure, applying ice to the site. And so those kinds of things can also be done. And if you have a question or you're going to think about this for a while, Erica's going to share with you a way to get those questions answered, where they can be routed directly to me, and I'm happy to talk with you about any questions you may have. The resources are here. Please use these resources. They've been developed by NHF, and they've been developed by people like yourselves who have gone before you. They've been developed by people like me who have had a lot of experience working with children with bleeding disorders. And a lot of thought has been put into these to help you along the way. But really, your biggest resource is going to be that healthcare provider. They're going to work with you. You're going to find out that you have a big family out there that may not be your biologic family, but they're going to be your bleeding disorder family, and you will come to know and love them, and you will use them as a resource. They should not be your only resource, nor should the internet. Social media has become a valuable part to our society, but they are not the place to go for healthcare advice. Your healthcare provider is where you should go. And I think Erica has shared her email. So if you have additional questions, please forward them to her, and we'll go from there. Thank you.
Thank you so much, Sue, for that presentation. We appreciate everyone joining us today for your time. My email. Thank you so much, Sue, for that presentation. We appreciate everyone joining today. We do want to remind everyone to go ahead and fill out the evaluation you'll get by email tomorrow. You do have to August 29th to fill that out. Please fill it out. There is a raffle as well to go along with it, where you can possibly get a $75 gift card. And again, the resources were posted in the chat with the links, as well as my contact information. If you have additional questions, Sue is happy to respond to you in that manner. Thank you again for joining. Have a good day.